I think we've had a very rich discussion today and covered a tremendous amount of ground. As we were getting ready, Dr. Nissen said he thought it was going to be a long time. I think we filled it up pretty well, actually. And I think we could go for quite a while longer. But I want to be respectful of everybody's time, including those of the people who are watching this discussion. So I'd like to thank each and every one of you. We've had a very rich discussion, very informative. I think a lot of us learned from each other. And so I'd like to open it up and get a couple of closing thoughts, and I'll ask Dr. Desai to start, please.
Thanks, Neil, and thanks for moderating, and thanks to Steve and Jaime for a wonderful discussion. And I think, as I sort of reflect on it, and I think about, where we've come with SGLT2 inhibitors, and we think about the patient with cardiovascular disease and diabetes and chronic kidney disease, and, there has to be a call to action now. That our clinical practice has to reflect the clinical evidence. And what we've learned about these therapies is that they are incredibly effective, though they were developed in many ways as diabetes medications, that what we've learned about them is that they are quite potent cardiovascular risk-reducing medications and even pretty effective heart failure therapies. And so, I think the onus is on all of us to continue to engage with our clinical colleagues and to continue to sort of practice the kind of high quality, high value medicine that we all aspire to.
Excellent. Dr. Murillo?
Thank you. I'll just add, first of all, thank you for a great conversation, a great discussion. And just say that we are definitely supportive of the guidelines. We're supportive of what means in clinical improvement for our patients. And that SGLT2 is not going to be a decision that we're going to deviate for. I think we believe that the results are valid, important. We support them, and we'll continue to refine this process. And with the help of the guidelines, especially, I think it's going to make it easier for us to say these are the group that will benefit from it, and we're not afraid of taking the lead.
And last but certainly not least, Dr. Nissen.
Well, thank you. First of all, I've greatly enjoyed the discussion. And Neil, thank you for moderating in such a skillful fashion. But, the dialogue has really been fantastic. I look back at this now 12 years ago. We dreamed when we made the decision that we were going to require outcome trials for new drugs for diabetes. I got to tell you that I never dreamed that we would find a class of drugs that could reduce atherosclerotic events, death, all-cause mortality, renal disease, and heart failure. And that the drugs might actually do that, have those benefits, not just in people with diabetes, but with other people as well. And so, I'm very, very happy that we were able to move forward in a field that had stagnated for decades. And it's been an explosion of new science. I just would leave you with one final thought. We need to better understand how these drugs are working, which I don't think we really understand very well, and we didn't talk about very much. And as we work toward implementation, we also want to understand the science better, and I hope we can do that in coming years. But it's been a dream come true for me, and I'm very pleased with what we've accomplished.
Well, I certainly would like to offer my thanks to everybody who participated this morning for, again, just great crosstalk and a lot of informative learnings. So thank you to all of you. I'd like to thank everybody in the viewing audience, and I speak for all of our panelists when I say that we hope you found this to be another informative American Journal of Managed Care panel discussion, and hope that you find it useful in your practice.